Welcome, everyone.
That's the chance. Okay.
All right, there we go.
The Ohio State. The Ohio State.
Welcome, everyone, to first grand rounds of 2024. I'm excited to have those of you who are here in person here, and also all the people on Zoom. So I thought it would be great to start our year off with having our associate dean for research talk about her research, because she's done a lot of great things this year. So I'm going to just introduce Teresa Hernandez. As you know, she's the Associate Dean for Research and Scholarship and a Professor of Nursing and Medicine here at the University of Colorado. And for over 20 years, she's conducted controlled clinical studies in pregnancy, focused on nutrition, glucose, lipid metabolism, infant growth, and early life exposures. So she's a cardiac nurse by training, pediatric nurse scientist at Children's Hospital currently, and has a dedicated commitment to understanding insulin resistance as both an adaptation and pathology. So she is director of the Colorado Clinical Translational Research Institute Early Life Exposures Research Program, elective member of the Perinatal Research Society, and serves in leadership positions for the American Diabetes and American Heart Association. So very excited to welcome her to present on In Defense of Carbs, randomized trial to challenge the low carbohydrate diet for gestational diabetes. So welcome, Teresa.
Hi, everybody. Great to see you. I saw the snow this morning and didn't know what to expect. So I'm so happy. And thank you for the invitation to present. I never expect that. So thank you. Thank you, Jen. So today, I tried to come up with a catchy title. We were just discussing that before Grand Round started, but today I will hopefully try to convince you about carbohydrates in pregnancy and their place in gestational diabetes, which historically, has not been the case. So I'll tell you the story behind these data, and a lot of this is based on sort of my lived experience over the last 20 years now. None of this work would be possible without like the most incredible team in the world. So I have that now. The team's grown. I see Elizabeth here. But here in the room, I know everybody can't see, but Nicole Hirsch is here with us today. And you can see her. She's in so many pictures over the years. Actually, Nicole was the mastermind who helped me run this study even before Emily Dunn came on board with our team. And so I'm really fortunate that the team followed me to the College of Nursing, and we're all here now and running equally compelling studies. But I just wanted to share that this was a truly team effort with my colleague Lynn Barber, also Jed Friedman, who's now at Oklahoma, and others shown on this slide. Here are my disclosures. If you hear me refer to Infant Gold, that actually is the name of our team, and it's an acronym, and it stands for Investigations in the Gestational Origins of Lifelong Development. So today, I would love to present an interpretive history of the choice diet, so the story of the choice diet, and make the case for flexibility in dietary carbohydrate content for gestational diabetes, which, as I mentioned before, historically, there hasn't been much of a case. And then I'll present some of the data from two clinical trials. The most recent, the last baby was born right before COVID hit, which was a little bit dramatic, but we were really happy about that. So I'll show you a bit of that. And so really this is a story that started when I was a graduate student. Now I look back and realize I didn't take enough pictures in the old days. But this is Lynn Barber, who became my primary mentor and remains my research partner. We look like kids here. This is in about 2008. But really, the original questions that came from working with pregnant women, the original questions that I asked started in around 2004 when I was working on my master's degree. So as Jen mentioned, and most of you know, I think, I'm actually a cardiac nurse by training. So my time on the obstetrics unit has been completely research related. But I was a cardiac nurse in Dallas, Texas, at a time in the 90s when really high-fat diets were sort of on gaining some momentum. At the bedside as cardiac nurses, we saw diet patterns as being as heavy influencers of cardiovascular disease. And so I took care of very sick men and women with cardiovascular disease. And in most of those individuals, I noticed when I was a bedside nurse that I also injected their insulin. So somehow, even in the 90s, when we didn't even have a name for the metabolic syndrome yet, it was called Syndrome X back then. There was no PubMed. Sort of when I came to Colorado, all of that experience as a cardiac nurse came with me. And then I started working in research. And essentially, you can see this is our original lab group at the old campus at 9th in Colorado. That's Bob Eccles' team. And so I came into a metabolism lab. And shortly thereafter, this is when I met Dr. Kathy Jankowski, who's also here today. And we, here's the old Barbara Davis Center. I started working with pregnant women, which was very different from my clinical experience at that time. And most of these women had gestational diabetes. So I began to spend a lot of time through these other research studies that we were doing with pregnant women, particularly with gestational diabetes. And as their nurse, they told me what was on their mind. They told me their stories. And really, I began to understand the GDM diagnosis. I was pregnant shortly, in about 2003. So for a while there, I was pregnant with them, but I did not have gestational diabetes. So I began to understand what it was like for these women, though. So, for these women, they went through about 2/3 of their pregnancy thinking that their pregnancy was normal. And then suddenly, end of the second trimester, their glucose tolerance test is positive, and they are given a high-risk diagnosis. They have a high-risk pregnancy label. They're put on, quote unquote, this diet, which I'll tell you more about. And really, the harbinger of gestational diabetes is rigid control of glucose, because one of the primary poor outcomes of GDM is fetal overgrowth and growth of basically macrosomia, what we call it in the field, or a big baby. So rigid glucose control is sort of the basis of trying to prevent that. They have more doctor's visits. They really get stressed when they need to inject insulin. They're given a glucometer. And really, I started to notice, kind of a psychology over time related to gestational diabetes. They were anxious, they had a lot of fear, and they have high rates of depression. So I began to notice that psychology. And if you talk to these women, and this has actually been shown by social scientists kind of across the literature, if you ask women what they hate most about the diagnosis, they'll tell you it's the diet. And that's because historically, the focus of the GDM diet or nutrition therapy is rigid, as I said, rigid restriction of carbohydrate. So imagine being pregnant when I had nausea, you have some saltines or some kind of carbohydrate. Like actually, these women are advised against that in many cases. It's really hard for them so late in the pregnancy to adapt to a completely different eating pattern. They're worried going to the grocery store, trying to read labels. A lot of women feel that this is an infringement on their cultural eating patterns. They want to eat with their families, yet they have to make a separate meal for themselves. So it's really an infringement. And imagine how we all feel being on a diet, in pregnancy. It's certainly amplified. There's a very narrow range of acceptable foods, and they feel very confined by the diet. And so really, again, if you ask women, and this has been shown across the world, diet is the most difficult component of treatment of gestational diabetes. And so back in those days when I was listening to women and spending a lot of time with them, they told me about their eating patterns. So for instance, they would go to McDonald's. Go figure, there's number one. And then they would get like the McMuffin and not eat the muffin. So they were literally eating just the meat, right? And so really what we noticed in our Denver population is that these women had rationalized over time that, well, I'm not going to eat any carbohydrate or very little because they associate that with their baby overgrowing. Now, early in those days, I was also in a lipoprotein lipase lab. I was a master's student. I was actually so profoundly influenced by their experience that I focused all of my master's degree work on gestational diabetes. I wanted to know everything that I could about it. Because really what worried me as a cardiac nurse is I saw these young women eating like my patients in Texas were eating. And it was as if I had glimpsed their morbidity. And so I became very endeared to this population. So where are we with gestational diabetes? These are some data, they're not yet published. I'm working on these data with some colleagues out in Oregon, where essentially we analyzed birth records from the National Center for Health Statistics between 2014 and 2020. In 2014, that's when the guidelines came out for universal screening of gestational diabetes. So we wanted to know, where we are in terms of prevalence of gestational diabetes. How are we doing with large for gestational age? And so there's a couple of things that are really interesting about the data. First of all, you can see that in that bottom line is GDM prevalence. We started out in 2014 with a 5.4% prevalence of GDM. And that has gone up by about, it looks like 2.4%, like if you calculate the crude increase, but if you calculate the risk ratio over time, it's actually a 43% increase in GDM. And so for sure, the slope is going up. But the good news is this top line is large for gestational age, one of the primary poor outcomes of gestational diabetes. And actually, there is a downward trend in that line, where the crude reduction is about 3.7%, almost 4%. But the risk ratio over time is a 20% reduction in LGA, which is good news because that means our therapies are working. Hypertensive disorders of pregnancy, we also wanted to factor that in because it's a major driver of gestational diabetes. And you can see that went up by about 3%, of course, crudely, and that equates to about a 27% increase in that risk ratio over time. So the main point of this slide is that despite lower gestational age, large for gestational age over time, which is really good news, the LGA prevalence in 2020 was still 15, almost 16%, compared to 9% in the control group, meaning women who didn't have gestational diabetes. And so really what that tells us as a field is that we haven't normalized that outcome. So to really normalize that outcome, we want it to be closer, really under 10% on a population level. Some LGA is just out there. So we still have work to do as a field. And so we made one of these cool maps that you see, the CDC makes these, and you can look at them for a variety of chronic disease risks. But here we made one for gestational diabetes. And you can see that in the left panel here is kind of the 2014 color map. And see how in 2014 we left off at 8 to 12%, and it's like dark blue. We actually had to add a new color when we made the 2020 map. And so just to show you here, you can see that there's much more, a shift to the darker blue really shows us what's happening with gestational diabetes prevalence. And I wanted to just point out on here, well, who has the highest and who has the lowest? So as of 2020, the highest GDM prevalence was actually 12.7% in Alaska. So indigenous populations, the Alaska group, they have the highest incidence of GDM, and it was lowest in Mississippi. And so, and actually what's really interesting, this is almost another talk, is so Black women actually don't develop GDM as often. They have other comorbidities such as hypertension. So it's just really interesting. And then here's Colorado. You can see that even in Colorado, we used to be the healthiest state, I'm using air quotes, but you can see that even our color, had to be kicked up a notch. And so we fall into that 7 to 8% prevalence. The global prevalence of GDM is 14%. So that's kind of where we stand in terms of global prevalence. So a little bit more on, kind of the history and sort of the state of science for where we are in terms of carbohydrate content for gestational diabetes. So I'm going to refer a lot to the idea of liberalization of complex carbohydrates, right? Because one thing I hope you'll come away with today is the idea that, you know, a carbohydrate isn't a carbohydrate. Like if we, by choosing the right ones, you know, we really think that that has a place in nutrition therapy for gestational diabetes. I feel like I'm always looking. Yeah, I can't see you guys over.
We're good.
here.
Sorry. We
Yeah.
can see you. We can see you. We're good.
Yeah, I'm trying to, be taller. So there's actually multiple definitions of low carbohydrate diets in pregnancy. So you can define it by macronutrient content. So historically, that's actually how the low carb diet and gestational diabetes was defined. That came about in 1990. And so that low carb diet, originally described by Dr. Lois Jovanovic, who was an endocrinologist, very committed to women with diabetes in pregnancy. That diet prescription was 40% carbohydrate, 45% fat, and 15% protein. So that's one way that we name a low carbohydrate diet in pregnancy. You can also use like crude or absolute carbs per day. And this is what the Institute of Medicine does. And so if you look at that guideline, which has been out for about 19 years now, what they recommend is that women with in pregnancy, this is not only for gestational diabetes, at least 175 grams of carb per day should be consumed. And that's largely to support mother's brain and the fetal brain. And that's what that accounts for. So most of us in kind of a free living diet consume, you know, roughly 250 grams. I mean, it could vary, but that's kind of average. So the idea is what the IOM is saying is that in pregnancy, women should consume at least that. Now in gestational diabetes, that gets translated into like a diet prescription, you know, throughout the day. And so a lot of the guidelines are focused on having women meet that target and not exceed it throughout the day. So when I talk about liberalization of carbohydrates, like I just want to be really careful about that because we're talking about an overall healthier diet eating pattern, higher diet quality. Again, a carbohydrate is not a carbohydrate. So what we're not proposing is eating lots of simple sugars and the kinds of carbohydrate that we know acutely raise postprandial blood glucose, right? And so complex carbohydrates are metabolized a little bit differently, slower. You could think about it after a meal pattern. And so that's a real basis of the choice diet, which I'll show you more data about that. Now, where do we stand in the field? I love this forest plot and it's too much to look at, but I'll give you kind of the idea. So, you know, 20 years ago, me included, there was this huge sort of momentum in the field to try to figure out which diet is the best. I mean, okay, I think that's great, but now here we are in an era of personalized nutrition, and the reality is that there isn't going to be one diet that's the best for everybody. But we all got on that bandwagon, and I was included in that. And it really wasn't until this meta-analysis was really important for the field, was just published in 2018 before the pandemic, where this group took a step back and finally said, you know, the carbohydrate restricted diet for GDM was actually based on experience before insulin, right? So before 1920, the only thing you could do to save somebody with type 1 diabetes, to save their life before insulin was, you know, one of them was to eat almost no carbohydrate. So the diet at that time was about 90% fat, believe it or not. And so that got translated over time when the GDM phenotype emerged. And then, you know, of course, it wasn't quite that extreme. But really, nobody had ever asked, you know, does diet effectively control maternal glucose? Does diet control fetal overgrowth or prevent it? And it was this group that actually did this really important meta-analysis. And what they found is that, you know, across 18 randomized control trials, only 1,100 women. So this is how bad it was for the field. For all the babies born in the world, we only have data on 1,100 women. So you know, we had a ways to go, but really they wanted to know, does any nutrition modification really improve these outcomes? And the answer is yes, that it does. And the reason that I know that is because if you take a look at the forest plot, and see how the diamond falls right to the left of the line there. That shows in favor of any improvement in your nutrition pattern when you get the diagnosis. So what they found is that across different diet patterns, low carbohydrate is only one of them. There was a reduction in fasting glucose. Postprandial glucose could be, reduced by about 8 milligrams per deciliter. Women, lower need for medication. And in fact, in only 9 of the studies, they could look at birth weight, but there was a reduction in birth weight. But the evidence was of very low quality. So that was actually a really important paper for the field that shows that, we've got some room for improvement here. And so if you look across, this is a 2017 Cochrane review, which sadly is still, there's not much new. So this came out in 2017. They assessed evidence from 19 trials, and they saw no clear differences from, these are mostly diets, one diet compared to another, looking at a particular maternal outcome. And I'll show you what those look like in just a second. So what we were seeing across the trials is that the evidence is very limited. There's a small number of trials, small sample sizes. The methodology was all over the place, so it was really hard to make comparisons. And so if you look across this variety of nutrition approaches, including the DASH diet, high carb, low carb, soy, protein enriched, high fiber, really, if you look down this whole column, you'll see that there was no clear difference in any of the primary outcomes. And so really what this is telling us is that one diet isn't superior, including low carb, which again became the mainstay for nutrition therapy. But really it's a sign that I think we have some room for improvement. And so the previous trials had several limitations. First of all, adherence or compliance. Either it wasn't reported or it was very poor. So nutrition research is really hard in this way, right? You ask people, well, eat this way. Well, how do you know what I even can't go home with pregnant women with GDM. So I'll show you what we've done, but compliance has been a huge limitation. Medication confounds metabolic outcomes. So if women inject insulin, how do I know that their improved glucose is from the diet or from their insulin, right? And you could say the same about birth outcomes. Phenotypic heterogeneity. So that is that is a huge limitation. Inadequate power. BMI has been inconsistently reported. And gestational weight gain, most of the trials would report total gestational weight gain, and then you don't really know what happened to weight gain on the nutrition intervention, right? So most women with GDM gain most of their weight before they get the diagnosis. And so it was hard to tease that out in these other trials. And then perhaps the biggest limitation is that you can't blind study participants to treatment. So even, that's just an inherent bias that in nutrition research, it just can't be overcome. So we have a lot of challenges, in the field. Historically, the focus has been all about glucose, right, in nutrition therapy for GDM. But actually, what this slide is showing you is that lipids and lipid exposure is another kind of feeder of the baby's overgrowth. And so what you can see here is just sort of a nice summary slide of 46 studies. It's a meta-analysis, but if you look here right here and see the triglycerides, this is what we're studying in our work. Triglycerides have really gained a lot of momentum in terms of our recognition of other drivers of fetal overgrowth with glucose. So in this case, birth weight was the primary outcome, but you can see just the number of studies that are starting to show that association. And so I'll just sort of summarize kind of sort of a model here for one way to think about this and how we approach this in our infant gold research group. So if you think about the infant outcome, after the baby's born, the baby's growth is largely to genetic potential. So as long as the baby has adequate nutrition, which usually, whether it's breast milk or formula, they do, growth is regulated by endocrine status. Now, the fetal environment is actually very different. Okay, so once the placenta is established and, that nutritional pipeline, as you can see here in the title of the slide, the nutritional supply line is functional, the baby, the fetus is completely dependent on maternal nutrition. In fact, pioneers in the field have described the womb as an incubation medium, where if you think of it as a petri dish, I know that sounds crude, but it kind of is. The conditions of the dish are created wholly by maternal nutrition. And so if you consider the fetus is completely, the growth of the fetus is constrained by the maternal environment and how much space is in there, but largely by the nutrient supply. And so I think of it sort of just to break things down in terms of these different compartments. And what we see happening now in the current day is that mothers bring their metabolic phenotype into pregnancy with them, right? And unfortunately, we see overnutrition now. There's problems with higher BMI. I mean, that can look very different, but there's also a metabolic phenotype that is pregnancy. We all have it. Those of us who can conceive, and it's driven by placental hormones, and that is insulin resistance. So Jen mentioned my career focus is insulin resistance. In pregnancy, it's actually a great model to study insulin resistance, where the pregnancy phenotype gets superimposed on the pre-pregnancy phenotype. And all of these different tissue beds actually produce fuels, right? That in addition to what we take in from our diets. And that may be, you can see these the G is glucose, amino acids. Free fatty acids is another substrate that comes from the triglyceride. There's the triglycerides from our diet. They're called chylomicron triglycerides. And also there's triglycerides from our liver, right? And that's called VLDL triglyceride, if you remember that from your lipid profile. And it turns out that the placenta has all the machinery that it needs to take in all of these different fuels. It has its own enzymes. And so all of these different fuels, which we believe are happening in excess, not only glucose, but also lipids, also amino acids, are able to be taken up by the placenta and then moved over to the fetal compartment. So the historical model that was actually proposed in the 50s in the post-World War II era to describe the effect of maternal diabetes on fetal overgrowth really is shown right here, where the heightened glucose leads to a higher fetal insulin secretion, right, in our little fetus here. And that actually ramps up the baby's growth, because insulin, remember, does more than just control glucose. It's a growth factor, a very potent one. Amino acids also can cause an increased fetal insulin response. And then free fatty acids move very, very elegantly across the placenta. And we end up with kind of a newborn phenotype that is representative of fuel exposure, largely nutritional exposure in the womb. And so that may look like increased birth weight. Often it's increased infant adiposity, right, which is a very strong predictor of later obesity and metabolic risk in these kids. In our group, we've actually shown that the infants can have more liver fat as a response to overnutrition. And so really the paradigm is, I know it looks really scary and it's a lot of fuels, but all of these things really, nutrition is a very powerful intervention to try to prevent this problem. Here, this is the problem right here, which is fetal macrosomia. This was a 19-pound baby that I think was born to a mother. I know, a 1-year-old child is about 20 pounds. So imagine that. So nutrition, very powerful intervention in this paradigm. So I'll tell you a little bit more about our approach and how we have, how we're trying to contribute to the field, and so that we can better understand the effects of nutrition and gestational diabetes. Here's Nicole with one of our infant gold babies, and I forget which one, but he's so cute. Okay. We love them. They're part of our families. So going back to when I was a master's student and moving into my PhD, I was sort of left with this question, like, why are we telling women to eat this way when they're at high risk for cardiovascular disease and diabetes? Like, I was concerned that the fat content in their diet actually may make them more insulin resistant, and it would just lead to more fuel exposure to the baby. So is this like some law of unintended consequences? That's what I was thinking about. And so, so I convinced my mentors that this was worthy of study, which actually was not very easy at first because low carb diets are like, I mean, that was GDM nutrition therapy, period. Like, and so it turned out that when we realized that the evidence was what it was, which was incredibly limited, that we could do some work here at Colorado on our campus because we actually have fabulous research facilities to be able to study this. So the first thing that I knew, and I worked with my mentors, is we needed to come up with a model and a way to study this. And we wanted to try to come up with a way to study nutrition in pregnancy, and specifically GDM, where we could overcome those limitations, at least as many as we can, nothing's perfect, that I outlined to you. So the first thing we did was we worked with our nutritionists here through the CCTSI. We have a bionutrition department. And the first thing I did was we recreated the conventional lower carb diet. So if you see low carb conventional, that's like our, that's our abbreviation for it. But basically we recreated the 1990 proposed 40% carbohydrate diet, which was the low carb diet for gestational diabetes. But then we needed a challenge diet, right? And so like when you're designing a clinical intervention, if you have two interventions that are really, really similar, like you either need thousands of people or you're not going to see a difference, right? So we needed something different enough. And so this is where our choice diet came from. And so that is an acronym. The other thing we realized years ago is that we needed to name the diets in a way that it didn't scare women. Because I mean, remember, there's a psychology here, and actually I don't blame them for feeling that way. So conventional diet was our low carb diet. And then the choice diet, which stands for choosing healthy options in carbohydrate energy, ended up being a 60% carbohydrate, mostly complex carb diet, 25% fat, 15% protein. Years later, the American Heart Association guidelines for lifestyle came out, and it's almost this exact diet. Like, I don't know how that happened, but it's great. Okay, so it mirrors the AHA diet. Both diets in all of our studies. So we really wanted to kick this up a notch. And so we wanted to control the nutrition intervention and provide all the food to the women. And we actually worked with women in our early cohorts, and they were incredibly enthusiastic because they liked the idea of not having to count carbs. So like they loved the idea of having, you know, it's kind of like HelloFresh or something now, but like all of our meals, of their meals were packaged. So both diets, you know, we split up the calories throughout the day. So they had 3 meals, they had 2 snacks. Both diets were eucaloric. So it was based on this kind of complicated equation that took into account their BMI and their physical activity. We controlled the types of fats, and importantly, we controlled simple sugars in both diets, because remember, any diet that's filled with simple sugars is going to raise their postprandial glucose, and we think that is also a driver for fetal overgrowth. Okay, and so I needed preliminary data. So the first thing we did was we got a small. Here's, of course, my watch is ringing right when I'm talking. We were able to get a small. What was the name of the old Dirk grant, Kathy? The Diabetes Endocrinology Research Center used to have pilot grants. Anyway, we got a very small pilot grant just as I was moving into my PhD work. And in fact, this was supposed to be my dissertation, but I had to change tracks because it turned out that we needed many more resources to study for these studies to work than I could do with pilot money. But we were able to set up one of the most technically difficult study designs that I've ever pulled off in my research career. And sometime in the hallway, I'll tell you about some of the doozies we've done. But we designed a randomized controlled crossover trial where we enrolled women right after GDM diagnosis, and we had them start on, they were randomized, either the low carb diet, the conventional diet, or the choice diet, and then they crossed over. And we did metabolic studies along the way. Just a couple of highlights, because I want to show you the big trial data. is that in that small randomized control or randomized crossover study, what I'm showing you here is continuous glucose monitor data. So back then, we call them CGMs, but continuous glucose monitors were actually new. So we had like kind of the primitive ones where they weren't wireless and the women wore a pager kind of thing with a cord. And by the way, none of them complained, but that allowed us to measure their glucose continuously every 5 minutes of the whole time they were on our nutrition program. So it was fabulous. And what I'm showing you is what that looks like, those patterns look like over 24 hours. It turns out that it was if I calculated this area under the curve for each of these lines, as kind of an exposure, like we don't know that the fetus will see it, but there's a good chance. It was 6% higher on the choice diet. Okay, but and then we were taking a look at this, looks like something happened after lunch, so we were able to do a little bit of fine tuning. But essentially what this study showed is that both diets controlled glucose very nicely over 24 hours. And the reason I was so excited about this is because we could have been out of business, 15 years ago if this would have shown that the choice diet made women hyperglycemic, right? But it didn't. And so that was the first thing. The other interesting thing to come from this study that was completely unexpected is we did test meal studies where women came into the clinic and ate breakfast with us. And then they hung out for 5 hours. We drew their blood hourly. And what you're seeing here is the pattern of free fatty acids after their meal. Okay, so free fatty acids are I know there was a lot of fuels on that slide, but free fatty acids are related to the triglyceride, right? They're cleaved off the triglyceride, and they are also a very potent substrate in terms of fetal overgrowth. And what you see here is that after their breakfast meal, okay, so this top line is the conventional diet, right? And then this lower line is the choice diet. And see how the free fatty acids came down lower after the choice diet? That's because of their insulin, right? And so it turns out that even though there was a 6% higher glucose, potential exposure over 24 hours, what this suggests is that after meals, that on the conventional diet, there's almost a 20% higher free fatty acid exposure. So it's sort of this, we don't know, we didn't know what this meant, but this was completely a new finding. And to me, it suggested that perhaps the conventional diet, the low carb diet, because of the fat content, was making the women a little more insulin resistant. So their insulin wasn't working as well to suppress these fatty acids. This was crazy. We took adipose tissue biopsies. I know it's actually not a tough procedure. And then we did in vitro studies to expose the adipose cells, first we stimulated them, then we exposed them to insulin. And what you can see is that women on the choice diet, after being on the diet for about 6 weeks or so, their insulin was working better, right? So see how the suppression was almost twice as good. This is a measure of lipolysis, or that free fatty acid release from the tissue. So this, I had to show you this because I love these data so much. This is very technically difficult to do, but this was enough. And there's me as a graduate student, sorry, sleep deprived. And in one of my mentor's offices, he had this big, it's a big wad of synthetic fat, right? And there's a button on there that says, what's your BMI? Anyway, it was kind of oily and it became sort of this funny joke. But anyway, and then in that crossover study, because some of the women stayed on the diets, through delivery, we saw a trend for reduced infant adiposity, right, in the women who had followed the choice diet for about 6 weeks. Very small number, but this was enough. This was actually enough preliminary data that got me my first R01. Very difficult to do. And so fast forward, the R01 that we ended up writing, we knew that the crossover data was great, but it was very small. So we needed like a bigger, better trial. And so we then moved into, once my R01 was funded, a parallel randomized control trial where no more crossover. We really wanted to randomize women as quickly as we could after their diagnosis and get them on nutrition therapy and then study them. So the hypothesis moving into that work was that after about 7 to 8 weeks of the choice diet versus the low carb conventional diet, we thought that we would see improved glycemia, better insulin resistance, I'm really ambitious here, reduced free fatty acids like we saw in the crossover. And then we thought that we would see less newborn adiposity as kind of that marker of infant adiposity, like birth weight, is a marker of nutritional exposure during pregnancy. And it's also a potent predictor of later metabolic health in kids. So we thought that the choice diet would reduce newborn adiposity. We used the same diet model that we'd already developed. And by now Nicole was with us and really was spearheading this trial with us and with the team. What I'm showing you here is just for those of you who were like Nicole's here, also the other Nicole, with nutrition therapy, like how I get a lot of questions from dietitians, how many grams of carbs is this? Because a lot of people think in terms of absolute carbs per day. And so if you see this graph, because these women had higher BMIs, we wanted them to be in a euphaloric state. We didn't want them on a reduced calorie diet, right? So we tried to have them on replete diets. And what that meant was that on the low carb, the conventional diet, they were taking in about 214 grams of carb per day. Remember the 175 IOM guideline. And then on the choice diet, it was 316. So like this was ample carbohydrate. And then you can see what the differences in the fat grams per day, and particularly saturated fat as a driver of insulin resistance. And then importantly, remember, it was really important that we controlled simple sugars on both of these diets. What we did, here's kind of a snapshot of our study design. We brought women in right after GDM diagnosis. A total of 1,392 women were screened for this study, led by Nicole and Emily and our team. Like it was a major undertaking because again, this was a controlled study, and so we had to include women with particular characteristics, and importantly, we wanted them to not need insulin if there was any way that we could predict that. So this was funded by the NIDDK. Our primary outcome was neonatal adiposity. Yeah, you can see some of their inclusion criteria here. And so what we did is we brought women in right after GDM diagnosis, around 29 weeks gestation. They immediately began a washout diet and they were randomized. Then kind of in this first week of nutrition therapy, we did some metabolic testing. We gave them a 75-gram 2-hour oral glucose tolerance test. We did another breakfast test meal. They wore a continuous glucose monitor. And then there's just those details. Then for 8 weeks after that first week, they followed our nutrition plan. We provided all of their calories. This was in collaboration with CCTSI. Sometimes we delivered their meals. We had frequent contact with the women. And then during these metabolic testing weeks, they wore the Dexcom G4. This was G4, right, Nicole? Yeah, continuous glucose monitor. So the CGMs are much, much better now than in the primitive days when we first started this work. We then measured the infants at about 7 to 10 days postpartum, and we measured their infant adiposity or their body composition. We call it PBOD, but it's an air displacement method that we use to measure that body composition. The women were incredibly, you don't know how this is going to go, but it turns out the women were incredibly the groups were similar, is what I'm trying to say. We randomized 59 women, as you can see. And we actually did pretty well. Like very few had to come out because they needed insulin or glyburide. 23 completed the study in each group. You can see that their BMIs when they came into the study were nearly identical. Their gestational age, again, no differences here. Importantly, their total gestational weight gain was not different. And also their weight change just during the nutrition intervention was also very similar. So they only gained about 2 kilos in our hands. And their days on diet it wasn't statistically significantly different, but you can see that women on the conventional diet, the low carb diet, had about 6 more days of diet exposure. Here's just a look at their weight gain. So one of the biggest criticisms of carbohydrate is that, oh, well, it just promotes weight gain. Like that's out there in the pregnancy. Like, the answer is yes, but okay. So by choosing the right carbohydrates, you aren't necessarily going to gain a lot of weight. And so we actually have shown that in this study right here. So that was one thing. I actually pointed that out in our paper. Here are their biochemical characteristics at study baseline. So you can see that even though there weren't statistically significant differences in their glucose or insulin, the women on the choice diet by an eyeball analysis came in a little worse off in terms of their metabolic state. Their fasting triglycerides were higher. Again, it wasn't statistically significantly different, but they were a little bit higher. Here's okay, this is a lot to show you, but I'll take you through it. So I'll show you the responses to all the metabolic testing we did. We tried to pick clinically relevant measures that would really help us understand the effects of isolated nutrition as much as we could, right? So they came into our clinic and ate breakfast with us, right, in that first testing week, and then again at 36 weeks, right? And so what you see in the top graph here is their glucose response to that meal. And then the bottom graph is their insulin response. Now, this was a pretty big meal. It was 30% of their total calories. So it was a large meal. You can see that the choice diet did produce higher glycemia, right, in terms of the postprandial response. So it was 11% higher after the breakfast test meal. And here's their difference in insulinemia. Triglycerides, we thought, oh, there's going to be this big difference, and yeah, there weren't. So their lipids actually were not different. So really, remember the women on the choice diet, randomized to choice, started out with higher triglycerides, but the diet itself did not make their triglycerides higher, right? So all pregnant women have an increase in triglycerides, and really we saw the same increase on both diets. So that's another thing that if you go back to the historic literature about nutrition, is that high carb diets are thought to promote hypertriglyceridemia, which again, in some circumstances can, but in healthier diet patterns, that's not what we're seeing. And that's what the choice diet showed. Remember, I was all excited about the postprandial free fatty acid response. We actually replicated that finding. And instead, what we saw in the new study is that the women on choice had a 21% lower free fatty acid exposure to the choice diet. So that actually, we're getting ready to publish that nugget of information in our next paper. So we did actually replicate that finding. No difference at study baseline. And then we also gave them an oral glucose tolerance test, like what you would do to test for diabetes, right? It's a 75-gram, 2-hour OGTT. We did extra blood draws in there to look at some other markers of insulin resistance and how they're doing. And so again, at 31 weeks, you can see there was no difference at all in their response to that OGTT, right? And this is their insulin on the bottom. But then this really interesting, I have some work to do, Nicole, we have some work to do on this. But what we saw at 36 weeks after 78 weeks of therapy is an interesting difference in the choice women. Only in the women on choice did their glucose response improve over time, and it was lower at 36 weeks, and their insulin was no different. So it suggests that their insulin sensitivity was a little bit better. Like I said, the hallway conversation, I have a little bit more work to do on this, but that was a very interesting finding that has not been shown. Other markers of insulin resistance also look the same. So this is an estimate called HOMA, which is based on fasting measures of glucose and insulin. And this is the women on choice, this light gray bar, and it actually reduced over time while they're pregnant, and that only happened in the choice women. But then the between group difference wasn't there at 36 weeks. So I was seeing a pattern here that I'm super excited about. But it seems that the choice diet pattern is producing some benefits that maybe we didn't expect. Here's their pattern of glycemia. And I promise I'll finish up in just a couple minutes. And so if any of you don't know me, these are my favorite data. Like I know I love the tissue data and it's so great, but I love CGM data. And they're overwhelming, but once we can get them into graphs like this, they really tell us a lot about the 24-hour snapshot, much more than you can get from just a finger stick after a meal. So what you're seeing is that this blue line is the conventional diet, and then the red line is women on choice. There were no differences at the start. Then over time, you can see that they both responded to diet, right? And so in this, the purple line is the choice diet and the conventional diet is the green line. And really here's all of them together. These red lines show us what the management targets are. So like when women go home and they do have their glucometers, the goals for glycemic control are 140 or lower at 1 hour, and then 120 or lower at 2 hours. What you can see from the CGM data is that both diets, again, did a great job controlling maternal glucose. And no matter how we looked at it, it was similar or better on choice. So here's just their postprandial measures. These are used in the clinic. So we always try to include measures that will help out the physicians and midwives and providers taking care of these women. So you can see the nice shift downward that they both groups responded to the diet. Only in choice did the 1 hour postprandial glucose reduce over time. Like again, like that's a really important clinical metric, and we weren't expecting that. Time in range is a newer metric for CGM, where you calculate it over a 24-hour period, and so the percent time in range is starting to, as data are emerging, is what I mean to say, is correlating, is associating with perinatal outcomes. And even outside of pregnancy with diabetes therapy, time in range is one of the newer metrics that correlates with other A1C, et cetera, other markers. What you can see is that in this study at the beginning, when they started at 29 weeks and then right before delivery, their time in range was excellent on both diets. And then we looked only at the nocturnal period, and it turns out we realize this now, we don't really know what glucose should be at night for a fetal exposure. Conventionally we think maybe it should be lower, but it turns out that we really don't know. And so if we alter that time in range to 63 to 100 at night, it looks like on both diets, actually, they didn't do as well. So that means that their glucose was higher than 100 at night. And we don't know what this means. So we're the first group to publish this, and now there's all this discussion in the field. I might have to do a follow-up. But the time in range over 24 hours, this right here actually shows that both diets, their glucose control was excellent. Now, the primary outcome was infant adiposity. And so I still remember when I was making this graph, Nicole, I can't remember if you were right there, but I was sweating because, you go through, this is years of work. And I'm like, oh my gosh, remember we thought that infant adiposity would be lower in infants exposed to the choice diet. And it turns out that there just weren't any differences at all. Any differences. Their birth weights were similar. Their percent body fats were different by 0.6 of they just aren't different at all. So once I got over that, I realized that actually maybe what this is telling us is that we have a range here that is possible for these women so that they can adapt their diets, right? And they aren't just doomed to a low carb diet, which is, kind of the standard approach across the board. So that is where we leave off. The data are newly published in Diabetes Care, which we're super excited about. That's the top journal in our field. And we're really hoping to get some influence clinical guidelines. Here's where I think our team is moving next. First of all, like the whole idea of cultural acceptability, most of the women getting GDM are are multiracial groups. And that really demands that we identify choices for them. And so a lot of what people say is, oh, well, people can't afford the choice diet. Okay, which is a fair criticism in some ways. But we've actually shown, we published this before the pandemic, we've actually shown we adapted the choice diet to these 6 different global eating patterns, including in Africa. Like it actually can be done. It's about making the right choices. So I think that this is an area that I want to move our work into next. Our current R01 is we're really excited about what's going on with triglycerides. We're not excited in terms of the babies overgrowing. We're excited to try to understand this as an exposure that goes beyond glucose and even beyond nutrition therapy. So in our current R01, we are looking at these exposures over the course of early pregnancy to find out if early lipid exposure, really is a contributor to that increased fetal liver fat deposition. And all of that would happen, if that were true, all of that exposure would happen before any treatment window for these pregnant women. So the idea is that maybe if that is true, it will identify a window early in pregnancy to start nutrition therapy and some of these different interventions. I also have a tremendous interest in carbohydrate thresholds now, including the low carb threshold, which most people, I'm kind of known as the high carb person in the field now. It is what it is. But how we study this and how we figure out how low we can go in pregnancy is of great interest. And so I'm working on some ideas for study designs and how we can examine that question. And so just this last year, we had another big paper from our group where we looked at the placental glucose consumption, like the needs. So the placenta is actually like a brain in terms of its need for glucose, but it's never been accounted for in any nutrition recommendations. So anyway, we are looking at this more closely, and I think we're pretty excited to move into this area. So just to finish up, I know we almost are out of time. Is there a case for flexibility in complex carbohydrate content? So right now, the current evidence is that it's very limited. Our data just came out. And by the way, our primary outcome was not different. So any of the other evidence that I showed you is secondary evidence, right? But I can tell you that across the board, what really diving into the trials, there's no clear difference in primary outcomes. So none of us can say you have to be on a low carb diet, right? So there's definitely some room for improvement. So superiority of one diet over another has not been shown. But again, the secondary evidence, if you take it, kind of as a gestalt and taken together, it does suggest that flexibility if promoting diet patterns, healthier eating patterns, complex carbs, lower glycemic index. Actually, there are some benefits in terms of mother's glucose metabolism, et cetera. But the really important message is that what we're not saying is just go eat all these carbs, right? It's about choosing the right ones. It's about limiting simple sugars, limiting saturated fats, and it's about an overall healthier diet pattern. And so here's where in Defense of Carbs, that's kind of where we came up with this. Really, we believe that these data tell us that there's some options for women, and that makes me incredibly happy, especially when I think back to those early days. These women are so depressed. I can't. I've committed my career to them, and I'll do anything I can to give them choices. And I think this is meaningful work. And anyway, I'm excited to move this forward. In terms of no carb diets, women are eating that way, and I'm concerned. I'm not the only one who's concerned. So that may be the next phase of my career, is really trying to identify thresholds. And I just wanted to say thank you all. This is our win picture just from this last year. But ever since I came to CU Nursing, you've all embraced our work and welcomed our team, and it's just wonderful. So thank you. And I know we're almost out of time, but I'd be glad to take a few questions.
Do you want to stop the share on the screen there, and then
Absolutely.
that way, go up there and and then that way we'll see all the Zoom folks,
Okay.
right in the red thing there where it says stop share.
What am I doing?
Stopping the share on the screen here. I'll do it.
Oh, okay. I see.
You see them?
Yeah.
And then
Oh, I see. Okay. They're just putting emails for, I will be glad. Yes, Katie.
Well, this is so great to see, and I've been hearing about this for years, but to see it all laid out is really wonderful. I wondered if your participants have access to the CPM data. And I was also wondering if you track physical activity, because usually diet and exercise.
Yeah. So Katie, Dr. Kistler just asked if our, the women in our study had access to their CGM data, their continuous glucose monitor data, and if we measured physical activity. So the answer is, I forgot to say this, thank you. There was no difference in physical activity. We just used, there's only one pregnancy physical activity questionnaire that's validated, and we used that one. So there were no differences. The women wore a blinded CGM. So that's actually really important because we did not want them to change their behavior just based on the glucose, at least for this study. But we made that information available to their providers after they had the measurement weeks so that we could, just so they had it for their clinical care and informing ways to go. So
Yeah, it's interesting just to see when you give someone with gestational diabetes the information, they can make huge changes without
Totally.
even telling them what diet they have to be on.
yeah. Yes.
That's great.
No,
Thank
I don't know.
you.
Email. Thank you, everyone online. I can't see you all. Thank you. Yeah.
Oh my God.